Hello, everybody, and welcome to the second webinar in our series of webinars concerning caring for people with early breast cancer. So let's quickly introduce ourselves. I'm Teresa Wiseman, and I'm a Professor of Cancer Care at the Royal Marsden NHS Trust in London, UK. And I'm also a member of the EONS Education Working Group. Meryl?
Hello, everybody. My name is Merel van Klinken. I am from the Netherlands, and I am also an EONS Executive Board member and a member of the Advocacy Working Group. And I work as a cancer nurse in a Dutch cancer center.
Hello, everyone. I'm Celia Díaz de los Ríos. I'm an oncology advanced nurse practitioner from Spain, and I'm also the co-chair of the Education Working Group in EONS.
Hello, everybody. I'm Mandy Shoebridge. I'm a specialist breast cancer nurse based in London. I've previously been a consultant nurse in one of the big London hospitals, and now I work for Breast Cancer Now, which is a UK breast cancer charity.
That's fantastic. So let's look at what we're going to be doing today. So some of you will already be aware, but just to recap, we've been sponsored to develop a mini-series of 3 webinars as education support for nurses caring for people with early breast cancer. The aim of the mini-series is to give you an overview of the knowledge and skills needed to care for people with early breast cancer. And here's an overview of the web content. So webinar 1, which some of you may already have attended, but don't worry about it if you haven't managed to access. The recording is on the EONS website, www.cancernurse.eu.eu. In webinar 1, which was the 21st of November, we looked at early breast cancer as a disease. We looked at pathophysiology, risk factors, genetic breast cancer, MDT work, and European guidelines and decision making. And then we also added to that an overview of early breast cancer surgery. And this was so that in webinar 2, we can focus on adjuvant therapies. So today, that's what we're going to cover: an overview of adjuvant therapies, including neoadjuvant therapies. We're going to cover assessment and management of treatment side effects and symptoms. And we're going to cover emergency situations and how to manage them. And then webinar 3, which is on the 19th of December, we'll look at the impact of early breast cancer on people and their families. We're going to look at living well during and after treatment, how to manage common symptoms, educating patients of signs and symptoms of recurrence, and end of treatment summaries. So without further ado then, let's start with webinar 2. So we've divided this webinar into 2, and this is the content. Part 1, we will cover anti-systemic treatment. We'll look at European guidelines. We'll discuss chemotherapy and targeted therapy. Then we will have a break for 10 minutes. And then Celia will cover part 2, which is looking at other adjuvant therapies, radiotherapy, endocrine treatment, bisphosphonates, emergency situations, and assessment and management of combination of treatment-related symptoms. So in terms of adjuvant therapy, neoadjuvant chemotherapy is given to reduce the size of the tumour to make it operable or to downsize it to enable breast-conserving surgery. It can also be given to reduce the risk of metastatic disease, especially in people with locally advanced disease. The decision to offer neoadjuvant chemotherapy should be made at the multidisciplinary team meeting and be based on the size of the tumour, the focality of the tumour, position of the tumour within the breast, and the ER and HER2 receptor status. The reason for giving adjuvant chemotherapy is to reduce the risk of recurrence, both local and distant. And some patients may have further chemotherapy after neoadjuvant chemotherapy and surgery if complete pathological response was not achieved. That is, that there's still disease present. But before commencing any chemotherapy and before any chemotherapy is decided or given, it is important to consider fertility and sexuality. Conversations about fertility and sexuality need to be had early on so that people with early breast cancer have a chance to think about the impact, consequences, and be prepared for what might happen. In terms of fertility, often people just want to get the cancer treated as early as possible and are not thinking about fertility. Some won't have partners, and others may be important to have the conversations, as it can have a huge impact on people, especially later on. People need to think about the options and choices before treatment. Having cancer and treatment impacts on relationships. It's also important when talking about fertility and sexuality that we're careful to keep our language neutral and sensitive. People may be easily put off or isolated if assumptions are made about their sexuality or relationship which are wrong. So keep language neutral by talking about partners rather than wife or husband, and using they instead of him or her, and be sensitive in your approach. Consequences of treatment and side effects can affect sexuality and sexual health, and Meryl will talk about this more in webinar 3. For some, there's a loss of femininity, or in the case of male breast cancer, a loss of masculinity. At this stage, it's really important to talk about using contraception during and after treatment, especially in ER-positive breast cancer. The risk of pregnancy is very real, and you will have heard from Mandy's slides in webinar 1 how common it is. So the reason we put this slide in at this stage is to stress the importance of conversations about fertility and sexuality early in the pathway. So what is chemotherapy? Obviously, some of you will know this, but we need to recap for those that are new to cancer care. Chemotherapy, cytotoxic chemotherapy, means poisonous to the cell. Chemotherapy drugs work in slightly different ways. For the most part, chemotherapy targets mechanisms by which cells divide. It prevents cells from dividing. The drugs do not distinguish from any other cells, so they may cause many side effects, which we will discuss later. However, for the most part, normal cells do recover. Cancer cells do not recover. So here is classification of chemotherapy. I've included examples of drugs in each class, especially those used in early breast cancer, so you can see the types of drugs which will be used. Antimetabolites work by agitation of the RNA and DNA synthesis, so stop cell division. They're very effective. And examples of these include 5-FU, which most cancer patients will receive, and also methotrexate. The next group is the alkylating agents. And again, most people having chemotherapy for breast cancer will receive these. They work by altering the cellular DNA, thereby inhibiting DNA replication. And examples of these are cyclophosphamide, which is given in early breast cancer treatment, as well as carboplatin, cisplatin, and chlorambucil. So they're a very common group of drugs used. Next are the anthracyclines. These inhibit RNA and DNA synthesis. For example, epirubicin, which again is used in breast cancer care. Plant alkaloids, which are also sometimes called meiotic inhibitors, include the taxanes and the vinca alkaloids. They work by disrupting microtubule assembly and thereby causing M-phase specific cell arrest. And lastly, but not least, the topoisomerase inhibitors, which inhibit the enzyme topoisomerase, which causes cell cycle arrest and apoptosis. So I'll just show you a slide of the cell phases so that you can see and be reminded about the places within the cycle that I'm talking about. Here you can see the cell cycle on the left showing the phases G1, S1, G2 and M. And you can see that DNA synthesis and cell division happens in S1, G2 and M. The cycle on the right, you can see, is rotated slightly where the different classes of chemotherapy drugs work. But you can see where they are there, the antimetabolites, the taxoids, the alkylating agents. So it gives you a good idea where you can, so that you can see within the cell cycle where the drugs work. I'm afraid this is a busy slide, but it does show you the whole pathway. And it's a replica of the ESMO guidelines slide that Mandy showed in the last webinar, but it also has examples of the drugs. So you can see the recommended pathway for all different types of breast cancer. And we will go through them though. But this one includes the drugs so that if you were to download the presentation, you will be able to see exactly where the drugs are introduced. Here are the ESMO guidelines for systemic treatment. The ESMO guidelines are also a really good resource, and you can access them freely on the ESMO website. You can also download an app so that you can access them without the internet. So you can see from this that people with luminal A will have endocrine therapy alone in most cases, though chemotherapy will be added if there's a high tumour burden. That is, more than 4 positive lymph nodes, or the tumour is 5 centimetres across or bigger. People with luminal B, HER2 negative breast cancer, will have chemotherapy and endocrine therapy. Those with luminal B that is HER2 positive breast cancer will have chemotherapy plus anti-HER2 therapy, followed by endocrine therapy. Those who have HER2 positive breast cancer will have chemotherapy and anti-HER2 therapy alone. and those with triple negative breast cancer will just have chemotherapy. So here you see an overview of the ESMO clinical practice guidelines for chemotherapy. You can see the initial divide is whether hormone receptive positive or negative, and then it goes into subtype. So the summary is that adjuvant treatment should start within 3 to 6 weeks after surgery. For the most part, people are given 4 weeks recovery time. Neoadjuvant therapy should start within 2 to 4 weeks of diagnosis and staging. All people with luminal-like breast cancer should be treated with endocrine therapy. Chemotherapy should not be given alongside endocrine therapy. Usually, you wait until chemotherapy is finished. It should be used based on the risk of recurrence. Radiotherapy can be delivered safely during anti-HER2 therapy, endocrine therapy, and non-anthracycline, non-taxane-based chemotherapy. When having both chemotherapy and radiotherapy, chemotherapy should be given first, followed by radiotherapy. And Celia will talk more about radiotherapy after the break. The added recommendations for neoadjuvant chemotherapy includes that it should be given for 12 to 24 weeks, which is 4 to 8 cycles, and that it's based on risk in terms of tumour burden and response. People should be given sequential anthracycline taxane-based regime as standard. EC is epirubicin with cyclophosphamide, and AC is doxorubicin or adriamycin and cyclophosphamide. GCSF can be given for those at risk of severe neutropenia. As I said earlier, chemotherapy does not distinguish between cells, so destroys rapidly dividing cells. Here are the main side effects of chemotherapy: hair loss, mouth sores, nausea and vomiting, constipation or diarrhea, neuropathy, rashes, pain, especially headache, and some people have trouble breathing. Other effects on blood cells include bruising and bleeding and a weakened immune system. This is especially important at the nadir. Nadir is the term that basically means low point. When a person with cancer reaches their nadir following each chemotherapy cycle, it means that the person's blood cell count are the lowest they will be during the treatment cycle. The nadir tends to occur 7 or 10 days after treatment, though some drugs can have nadirs as far out as 21 to 28 days. The nadir is important with regard to neutropenic sepsis, which Celia will talk about in part 2. It's also important to note that gastrointestinal symptoms and signs typically occur 3 to 5 days following treatment, and usually have resolved by the time the nadir approaches. We've used the ESMO guidelines again in terms of recommended advice on managing chemotherapy side effects and the information we need to give patients and their families. So you can see here increased risk of infection. The advice is to plan and prevent, be vigilant and watch out for warning signs such as fever, fatigue, cough and diarrhea. Practice good hand washing and general personal care and hygiene. Stay away from people that you know are sick and have active infection. get vaccinated, which of course has been really important in the late pandemic. Eat well and stay hydrated. Keep hot foods hot and cold foods cold. And it's important to explain to patients that they need to report promptly to the team any signs of infection, fever, progressive cough, diarrhea, or any symptoms. It's also important to explain to patients that they must avoid people who have had live vaccines, because this could cause them a lot of problems. In terms of sore mouth or mucositis, advice about brushing teeth twice daily and flossing is important alongside rinsing with a warm saline solution several times a day. If mouth sores are a problem, they can be treated with Oragel or a lignocaine-based mouthwash. If infected, they can be treated with antibiotics or antifungal drugs. In terms of loss of appetite and taste changes, the advice to give is to stock up with foods that they like and to eat small meals and snacks throughout the day. To supplement with high-calorie foods and well-seasoned foods. The sense of taste often puts people off their food. So if you've got well-seasoned food, then it changes the taste. For fatigue, it's important to advise patients to get treated for any conditions which might make fatigue worse. For example, depression, anxiety. To plan an exercise routine and to get moving, and to take time to relax and practice a good sleep routine. Nausea and vomiting can be treated prophylactically with antiemetics prior to and immediately following chemotherapy administration. It's important to advise patients to report if their nausea and vomiting continues more than a few days after chemotherapy administration. Advice concerning diarrhea includes taking anti-diarrhea medicine and probiotics, but again, advising patients to report it if it's a problem. A useful resource for people with breast cancer having chemotherapy is this. It's 10 top tips for managing chemotherapy side effects. And this was developed by people having breast cancer treatment linked to MD Anderson in the States. And these are their 10 top tips for other patients. Get some rest, stay hydrated, eat when you can, create a sense of normalcy in your routine. Look at your support and care teams to have your back through treatment. Keep things around that bring you comfort. Stay ahead of your nausea, stay positive, prepare for possible hair loss. And remember that everyone experiences with chemotherapy are different. So those were 10 top tips from patients to other patients. So let's look at targeted therapy. Targeted therapies have changed the landscape for people with HER2 positive breast cancer. As Mandy explained in webinar 1, people with HER2 breast cancer have an overexpression of HER2 on the surface of the cells in their breast, which causes the cells to grow and divide at uncontrolled rate, leading to tumour growth. Targeted therapies block the HER2 receptors to avoid them receiving growth signals. Trastuzumab, Herceptin, is the most common, but other targeted therapies are being developed all the time. However, like any drugs, targeted therapies have side effects. And the most common side effects are nausea and vomiting, fatigue, mouth sores, diarrhea. The uncommon but serious side effects are liver problems, heart failure, and pneumonitis. And patients need to be monitored closely if there's any chance of them having heart or liver problems. So we need to monitor their heart and liver during their treatment. For people with HER2 positive early breast cancer, as I showed before, recommended care is 1 year of trastuzumab with or without additional chemotherapy. Again, as I said, it's important to do regular cardiac monitoring before and after treatment due to the risk of cardiac problems. And for high-risk patients, 1 year of combined trastuzumab with pertuzumab therapy can be given, or extended anti-HER2 therapy with niraparib. If there's still any residual invasive disease after combined neoadjuvant chemotherapy with anti-HER2 therapy, adjuvant trastuzumab could be replaced by adjuvant TDM1. So in summary, we've covered the rationale for adjuvant treatment, the European guidelines, chemotherapy, targeted therapy, and finally, side effects and how to manage them. We will now have a 10-minute break, and then coming up in part 2 will be Celia discussing other adjuvant therapies, radiotherapy, endocrine treatment, bisphosphonates, emergency situations, and assessment and management of combination treatment-related symptoms.